Okay, welcome everyone to the Anaphylaxis Campaign's webinar on managing your allergies in the time of coronavirus. We're joined by panelists Lynne Regent, CEO of the Anaphylaxis Campaign, and Professor George Toit, paediatric allergy consultant and Anaphylaxis Campaign clinical panel member. Just before I hand over to Lynne, just to explain that we're going to be answering questions that have already been sent in to us, but if you do have a question during the webinar, you can also use the Q&A function just to send in your questions, and we might be able to answer a few of those as well. And also this webinar is being recorded and the link will be available from tomorrow. So thank you very much. I'm going to hand over to Lynne now.
Good evening, everybody, and thank you for joining us this evening on the first of our Zoom webinars, and this one is on managing your allergies in the time of coronavirus. We've had a very significant number of calls on this topic, and I'm absolutely delighted that Professor George Toit has agreed to join me this evening to talk about this issue and to answer some of your questions. George has been a huge supporter of the Anaphylaxis Campaign for many years and is a member of our clinical panel. So thank you, George, for agreeing to join us this evening.
Thank you, everyone, for joining us on this beautiful summer's evening.
We've divided the topic up into a series of sections, and I will give George the general heading and he'll talk about that. And then if we've had any questions specifically that we haven't been able to cover up to that point, I will pick them up and pass them through to George. We've got quite a lot to get through this evening, so if we can start with the first area, which is allergy clinics and access to services. George, we've had a number of questions about what's happening with regard to allergy services during this period.
Yes, these are obviously unprecedented times. If somebody had told me we'd be in this situation a year ago, I'd tell them they're going crazy, they're dreaming. So this pandemic has caught us all off guard. And my experience is at St. Thomas's in the Evelina. Our clinics have now, the face-to-face clinics have stopped. We are doing everything remotely. And I can come back to that, but there are a lot of lessons we've learned through remote consultations. We still have a day a week where we're doing procedures that need to be done. So omalizumabs, biological injections, venom immunotherapy. So we are still seeing patients. And this is true when I look at trusts throughout the country, that I'm unaware of any trusts that have continued with regular face-to-face consultations. All consults have turned into telemedicine consults, and this works well up to a degree. It's obviously quite optimal for taking a clinical history, for advising on possible acute reactions, but there comes a stage, obviously, where you do need to do some additional testing, either skin prick tests or IgEs. And so that'll be the next challenge, is opening up our doors again to get patients through to do the testing. And that time will come. We won't be closed forever. This handbrake of a lockdown, I think we can all feel, is slowly being released. And hopefully, if short of a massive second wave that puts us all into hibernation again, hopefully there will be more and more opportunities for testing and ultimately then face-to-face consultations.
Thank you, George. We've had a question that has come up that I would like to put to you. My 2-year-old son has multiple allergies, and his food challenges have now been cancelled for the foreseeable future. I'm concerned that we are leaving it too late to introduce some of those food groups into his diet. What advice is there around this? And we've had a number of questions around this area.
Yes, so this understandable anxiety about wanting to get foods in stems from our Leap and Eat studies, whereas people know foods, particularly peanut and egg, were introduced early with great success for the prevention of those allergies. So many families are picking up now on international guidelines. So there's one government in the world that actively advocates the introduction of peanut for young infants, and that's the American government through the NIAID guidelines. In the UK, there's societal guidelines. In Australasia and many other countries, people are encouraged to adopt a broad, expansive diet. And if there are at-risk factors, the earlier you do this, the better. Now, we believe that the benefit is largely achieved in the first year. For the prevention, the window of opportunity is at best around the milestone of sitting, approximately 6 months of age. By the time a child gets to a walking milestone, around 12 months of age, very often the allergies already have their onset. So what I'd say to this family of the 2-year-old is just keep them safe. There's no drastic pressure to introduce these foods at 2 years of age. It would be nice to expand the diet for safe dietary expansion, quality of life improvement. But at this age, there's no evidence that you're going to be preventing allergy. Now, if this was a 4-month-old infant with eczema and other risk factors, then we have a bit of a dilemma, because currently it's very difficult to access any testing. And we know that this benefit is achieved if you can go ahead and do that. So we may come to that in a later question. But for this family with a multiple food allergic infant, 2 years of age, I would just keep them safe during these times of corona. You don't want to take chances at home, land up in A&E settings.
Thank you, George. I'd like to move on now to the next section, which is about accessing hospital services generally. And, you know, when children or adults have an anaphylactic reaction, the advice is use your adrenaline injector, use the second one after 5 minutes if you need to, dial 999 and go into hospital. And then in normal times, people would stay in hospital for children very often overnight. And there's a general nervousness now, I think, from the allergic community about going into hospital. So perhaps if you could talk a little bit about what happens now when patients go into A&E.
So the allergy management pathways will be the same as before. Things will appear different. People will be wearing more masks, more gloves. Patients in A&E will be separated. But the A&Es are open for non-COVID business, and that message has come out very strongly from central government and from many hospitals, even our own. We've had to put out messages to our community to say, come to hospital if it is still indicated. So certainly don't stay at home. Follow your emergency plan. I have one right here. Hopefully you can see it. So this is the plan generally we are all using in the UK. As Lynn says, it gives indications for using adrenaline once if things haven't settled after 5 minutes and no help is to hand. Medical help, which is, you'll be very lucky to get help within 5 minutes. You administer the second EpiPen or equal adrenaline device, Jex pen, which is available at the moment. And of course, you would then go, because of delayed reactions, and there is a warning on this emergency plan that a few hours after your initial reaction, you can have a subsequent reaction. So it's best to be observed in hospital for at least 4 hours to see if that's going to happen. And if that happens, it'll be in a safe and supervised setting. And that guideline is the same in the US. People were encouraged then soon after their first adrenaline device to go into the hospital setting, and it's now been slightly liberated to say you can give the second one at home before heading off to hospital in the hopes that you won't need that. But our A&Es are open for business. We're not overworked, we're not swamped. Please, may these reductions in COVID cases continue to go down, but we can deal with allergic cases in A&E.
Yeah, thank you for giving that message, George. We have had a number of calls on that particular area because people are still very nervous, and that's absolutely understandable. We have had a question around that area, so perhaps if I could ask you that. Before lockdown, my child was given the all clear to take food allergens in the home setting, but I have been too nervous due to concerns about visiting A&E, should she require medical assistance for an allergic reaction. What would be your advice regarding home-based introductions during lockdown?
So obviously it's very difficult to give specific advice because the history is that the child was given the all clear, and I wouldn't know what that was based on. But if you have a negative allergy test and you're exposed to the food soon thereafterwards, the chance of you reacting is exceptionally slim. The negative predictive value of a negative test for many foods is around 98, 99%. Those are enormous odds that your child will be absolutely fine with exposure. So if you've had some testing and the all clear, like with all other healthy foods. And remember, common allergens are healthy foods: the eggs, the milks, the peanuts, the cashews. They're full of protein, they're satiating, they're nutritious. If you're not allergic to them, bang them into the diet nice and early, particularly if you've been given the all clear. Now, if you're too nervous to do that, so if you look at peanut in our LEAP study, the early introduction conferred a relative benefit, a relative risk of 81%. So not everyone was spared from doing it, but most were. So if this is an at-risk infant, you've had negative tests, you've been asked to introduce it, you want to get going early. If they're a little bit older, it's probably there's probably less urgency around it. And if you are crippled with nervousness around that, just wait another few weeks and hopefully services will start opening up. Communicate with us, so email or phone your services, tell them you're anxious, tell them this was their advice, and give them that background history, and your doctors will act on this.
Thank you, Judge. I think that's very important that people feel that they can ring their specialist, the clinic, or ring their GP when they need advice and not sit at home and worry. And I think that that's great. So thank you for reinforcing that. The next area is looking at managing allergens during this period in the community when people are out and about. We know that the lockdown stages are gradually being lifted. And ironically, I think for a lot of people, when we had complete lockdown, they knew where their teenagers and their children were. They were the only ones who were actually giving them food. And ironically, they probably felt a bit more reassured. But things are now changing. Young people particularly are going back out into the community, etc. And what sort of advice could you give around that area?
So I agree with you. Much of the COVID advice, the hygiene, the spacing, the supervisions and family unit cohesions increase safety. The increased hand washing is for many reasons a healthy thing, so that confers a fair amount of safety. I've been doing lots of remote consultations and very few patients have reacted at home in the interim. Occasionally somebody orders a different flour that may have, you know, lupine or a different protein within it. But most patients have enjoyed a reaction-free lockdown, in my experience. Of course, there is some risk with pre-ordering products. If they pre-cooked or pre-packed, people were very worried about the COVID risk of the packaging. It's a separate health issue, but generally those have been wiped down or sprayed by most families just in case they'd been contaminated. With the pre-cooked and the pre-prepared meals, you've obviously maybe outside your comfort zone. You won't be in the restaurant. Many of these restaurants are just doing takeaways. So you'd want to be very sure that you know what you're ordering. That's a scenario that will increase risk during lockdown, as opposed to when you can just call the chef and go in and say, look, my child's allergic to X, Y, and Z. Please be careful. Of course, you can still make those calls, but perhaps the message doesn't get through as well when it's not face-to-face. There are other factors around COVID that people are wearing masks, so that, or at least face coverings, so that may confer a degree of safety to them. We like our hay fever patients to wear these anyway. People are scared of sneezing and coughing patients now, so it may be the hay fever setting them off, and others around you may worry that it's COVID related.
I mean, it's very interesting because we've had a number of calls from people who have had, particularly if they've been isolating and they have allergies or they have a child with allergies, and people have been very generously knocking the door with homemade food and food parcels and so on and so forth, and people have been ordering food online. And the messaging we've been giving very, very clearly is, don't let your guard down. Behave as you would always behave when you are presented with food. So always make sure you read the ingredients. If you're ordering online, be very careful to check the ingredients list if you're sent a substitute food. If somebody very generously makes you some food and knocks your door with that food, it's okay to say, that's lovely, thank you very much, but I can't actually take it. It's about not taking any risks that you wouldn't take when the world was in a normal situation. Yeah. So thank you, George. That's very, very helpful. Now, the next area is one that, as you can imagine, we've had lots of questions about, and it's about children returning to school. And at the moment, I don't think the picture is clear about in which areas children will be returning to school. And we know it's certain year groups that will be returning to school, but there's a lot of anxiety from parents of allergic children about them returning to school. Is there any sort of advice that you could give around that area?
So I get there are many aspects around that. The one is how this affects the family unit, and speaking to many families as you do in the campaign, you can appreciate that they're unique stresses, that there may be multiple siblings in the family. Some will go to school, some won't. There'll be a fair sort of family stress around that. If there are still some children at home, then even if the parents want to go back to work, that may be very difficult to manage unless they get help or staff around that. So there's that sort of emotional stress. There's been a huge stress around the disease process itself. If I could just reassure people that uniquely with this virus, children seem to be spared. The complications that we all hear about, and I'll happily talk about if you want, are exceptionally rare. Most children will be asymptomatic or only have mild to moderate symptoms. They appear to acquire this disease far less frequently than what adults do. And although studies vary slightly, this fear that we had that they were super silent spreaders doesn't seem to be true. So the risk from COVID is very low to your children. Of course, there's a risk keeping the whole thing is about risk management. Keeping them at home compromises education, development, family harmony if things aren't going well. And we want to get our kids back to school. So I'm very pro the slow graded return. At the moment, the reception year 1, year 6 is if that goes ahead. And so what those kids are 4, 5, 6, they're very young at the beginning, and then 10 to 11, the year 6s are around 10 to 11, aren't they? So the 10 to 11s can understand this process a bit more, fend for themselves, understand the risk from food allergy. 4 to 5 years old is a little bit more complex. And when you read through the government's guidelines, so on gov.uk, they have many tips for returning to school. Now, some of them are obviously common sense. The schools must achieve distancing, if it's possible with young children, must achieve increased hygiene, so washing facilities, spray down facilities, increased cleaning. And then when it comes to food, which is of a huge concern to lots of our families, it offers tips. And this is obviously school dependent, depends on how many staff you've got. But one of the tips is to separate those children eating, which if they're eating their own food and they're not kids who will scavenge and grab food from others, and they are supervised, may increase safety. But if they're left to their own devices and they will eat from other children, that decreases safety with respect to food allergy. So some of these concerns will be school unique, family unique. But if I could reassure folk that the COVID risk is very low. And in truth, this risk is likely to be with us for a very long time. So if we don't tackle it 1st of June, the anxiety around that will probably come up in a few months' time, where the data may not be much more reassuring yet.
But can I ask you just a specific question that we've had on this, George, because it's come up from a number of people. I've read about a rare but serious Kawasaki type response for some children who catch COVID-19. Are you aware of any link between children with allergies and this reaction, as they are all autoimmune issues? Should this influence our decision about our children returning to school on the 1st of June? And this is a question that we've been asked many times over the last few days.
Okay, so the media have dined out on this Kawasaki syndrome. Yeah. It is exceptionally rare. There are many other everyday risks of rare diseases, of rare events that statistically are on that same level that we do not worry about. So I wouldn't overtly worry about the Kawasaki syndrome. There are very few children complicating with this. Of those, and we've had many at the Evelina that have come in, been one of the centers of interest. Of those, many didn't go to intensive care. Those who did go to intensive care, all except one did recover and eventually, did well and were able to be discharged. So it's a syndrome we've known about for a long time. It's being caused by viruses. We think it may be caused by COVID. We can't prove that it's caused by COVID in all the children, but the fact that it has had an increase in prevalence at the same time as this pandemic seems to make biological sense that the two are linked. But I would not worry about that syndrome when sending your child back. It is exceptionally rare. As far as being related to allergic conditions, no. Children with allergies are not at greater risk of catching COVID. They have a hyper immune system as opposed to a hypo, an underperforming immune system. So they're reacting to aeroallergens and food allergens that are seemingly benign to most of the population, but to allergic folk, they have this hyper reaction. And allergies aren't an autoimmune condition. So autoimmune is where your immune system turns on itself, like rheumatoid arthritis or heart disease or other rheumatoid conditions. It's an entirely different phenomenon. We need all the customers we can get. So it's not an autoimmune condition. It's not related to allergies. It's exceptionally rare. And the first part of the question is, what is it? Well, it's a vasculitis. It's a syndrome, high fever, mucocutaneous, so mucous membranes inflame. Your inflammatory markers all go very high. So these are blood tests that go sky high. The kids are very sick with it. And you can, as a complication, develop inflammation of some of the vessels. The one we worry about is heart vessels. But those are all exceptionally rare. They're getting a lot of media time and really are scaring families. And I understand why that is the case, but it's a rare phenomenon.
Thank you for that, George. As you would imagine, when those sorts of subjects hit the headlines, be it on the BBC or be it in the newspapers, etc., then we understandably do get a number of calls. So that is very reassuring. So thank you for that. Another question which we get asked a lot, actually, is a very simple thing, is should children with allergies wear face masks in school, and should these be of a special type? We get lots of questions about face masks.
Yeah, so I think we should follow the government guidelines when out and about, wear a face covering as opposed to a medical mask, because we don't wish to use up the PPE that the health service and social carers need so much. So there are various reasons for doing this. It probably won't protect you from inhaling this tiny little virus that will make its way through your mask. But if you are sneezing and unwell, you'll express less particulate when you cough and sneeze through the mask. So it's a service to society and a very mild service. There's one reason I like people to follow this when out and about, and that's that it reminds all of us that COVID is still a very real phenomena. It's a bit like wearing a medical alert bracelet. It's just a reminder to folk. It's got some information on it because it's not a normal thing for people to be wearing. So they see you with a mask and they understand and get reminded to be cautious, to wash their hands or wipe their hands. If you've got hay fever, as I alluded to earlier, you don't want to be sneezing in society and having your upper respiratory cough with this, because people will run a mile. They'll all think you've got COVID, and they'll be a bit more reassured if you wear a mask. The government guidelines aren't to wear gloves. If you wore gloves, and you touched virus particle and you hadn't protected your eyes, but you had face covering on, you could still get infected through your mucous membranes or your conjunctiva of your eye. So unless your eyes are covered and your face is covered, if you have virus on your gloves or your hands, you can contaminate yourself. So there's little point in wearing gloves. It's very hot to wear gloves. I'm not sure children will keep them on for too long. As far as going to schools, I read through the gov.uk guidelines and I didn't see recommendations for in-school face mask wearing. And certainly the recommendations are not for very young children to wear these. They could asphyxiate or they become very scared. That's when I have seen kids have been tested, urgent need for allergy testing, and everyone's wearing masks. It's very frightening for them if they're not used to it. So if you are going to return back for vaccination or some kind of medical intervention, you probably want to just scale your kids up, get them used to looking at you with a mask on, because often they'll make the parent wear a mask and try and put it on the child, and it's terrifying for them if they're not familiar with that.
Thank you very much for that, George. Though those are the sort of key points that are coming in and that we have been asked in advance of this conversation, and I think that's very reassuring. It's very difficult at the moment because it's very difficult to distill a clear message sometime when there's so much noise in the media. So this is really, really helpful. The other area that I wanted to talk to you about, because it's one that keeps coming up, is the availability of adrenaline auto-injectors. Now, we know that over the last few weeks, the 150 and 300 Emerade were recalled, and now at the beginning of this week, the 500 Emerades have been recalled. But I think people would welcome reassurance about the availability of adrenaline because we are still getting a lot of calls from people who are worried. And of course, our advice remains exactly the same. Always carry two, always have them on your person. If your adrenaline pen is changed to a different sort of device, make sure you know how to use that device. But perhaps you could talk a little bit about the adrenaline situation at the moment.
Correct. So we had 3 devices, of which one now is withdrawn, the Emerade. So we're down to the Jext and the EpiPen, and we have been told by the companies that the shortage has been addressed. So these devices should be flooding back into the market, feeding down to pharmacies and accessible. There was a recommendation that if you couldn't find an in-date device, at least for the EpiPen, and I believe that was extended to Jext, you could still use the device for a few months, very few months, still carry it afterwards, and it would still be valid. But if you can access in-date, which is ideal, and schools will demand that they're in-date devices, then obviously do so. And hopefully that will improve. This has been a huge frustration to patients. It takes many phone calls to pharmacies, to doctors, to try and resolve the scenario, and it's used up a lot of time and a great stress to folk. So hopefully that's improving. There has been stress about losing the 0.5 milligram EpiPen dose. So 0.5 is ideal when you're 50 kilos. 0.3 matches a 30 kilogram body weight. The biggest devices we can get now, the biggest dose is 0.3, both in Jext and EpiPen. So if your child is heavier than that, people would worry that uptake would be less, and if the needle was a bit shorter than the Emerade, that uptake would be less. But I'm happy to say, and this manuscript is now accepted for publication, but the data has been shown, so it's public access. We have done trials on big patients, very high body mass index, obese, and then overweight, and then regular weight adults. And we've used the shorter needle. This study was done with the EpiPen device, and the EMA demanded that these studies are done. So we fulfilled those criteria, and we tested this device on very thick thighs, where you wouldn't imagine that the adrenaline and needle would penetrate the muscle sheath to inject the medicine into the muscle, which is where it has its effect. But when we measured the uptake in the bloodstream and the change in blood pressure and heart rate, this medicine was still adequate. So I don't want folk to worry about not carrying a 0.5, but certainly carry 2 0.3s. And if you are a larger individual, then definitely always make sure you have your 2 0.3s, because you may well need the dose.
Thank you, George. That's great. As I say, we're still getting a number of calls, and I'd just like to interject here that if people are having difficulty getting Jext or EpiPen, if they contact our helpline, and we will talk to them and help them through that process. There was script validation on EpiPen, but that's now lifted, and both the distributors of Jext and EpiPen are continually reassuring us that there are plenty of supplies of both adrenaline auto-injectors. So thank you for that. I've got a few questions that have come in, and perhaps if I could put 1 or 2 of those to you, George, is that okay?
Oh, yeah.
The first one has come in from somebody who's listening live to the webinar. We have an EpiPen for our 6-year-old, but not for our 6-month-old baby. Can we use the EpiPen for the baby if needed in an emergency?
So the smallest commercial dose you can acquire in the UK is the 0.15 milligrams, ideal at 15 kilos. Your younger child at infancy would likely be lighter than that. The dose is safe from 7 kilograms up. So as long as your older child has a 0.15 and there was need in the younger infant and their body weight is 7 kilograms or greater, yes, you may use the same device.
That's great. And this gives me the opportunity just to remind people that it's important that they check that the EpiPen that they have or the Jex that they have for their child is of the correct dose, because one thing that we do find is that because sometimes mistakenly the 150 is called the junior and the 300 the adult. Some children who need to be on the 300 are not on the 300. So just making sure that that's discussed by individuals if they've any doubt with their prescriber, because children as young as 9 and 10 can actually require the 300. So that's worth thinking about.
If I could just reassure the family that 6-month-old infants, the need for adrenaline during food-induced reactions is exceptionally low compared to older children. So we've done, hundreds of these food challenges in young children in our trials, in high-risk children to peanut and other foods. And certainly in the LEAP study, we didn't use adrenaline once in the very young infants. As the children get older, they seem to be more at risk of more severe reactions. So you can use the device if you need, but at 6 months of age, children seem to make their way through these food challenges, although they're horrific and swell up and they may, look very uncomfortable during the process. Mostly it settles either spontaneously or with some antihistamine. If you're worried about respiratory symptoms or a child goes floppy and gray and unrousable, altered voice, cry quality, then obviously use the adrenaline.
Thank you, George. Another question that's come in, and I recognise this one from when I've been helping with the helpline over the last few days, is I am prescribed steroids for my asthma. Does this put me at more risk of coronavirus?
So regular inhaled steroids does not put you at more risk, does not cause a degree of immunosuppression that would put you more at risk. So that's an easy question to answer. Oral steroids would put you, so if you meet the British Thoracic Society guidelines for shielding, where you have to be, locked down supreme to be very cautious not to catch COVID. So those criteria are a diagnosis of asthma, obviously, a maintenance inhaler, which you'll obviously be on, and then frequent oral steroids, or if your doctor was able to get away from frequent oral steroids and use a biological drug on you, that would require shielding. So that would put you at risk, not so much of catching it, although you'd be slightly immunosuppressed, but also of not only of catching it, you'd be at slightly increased risk, but also of a slightly more severe course. So you want to shield, you want to be cautious if you meet those rather rare criteria.
Thank you, George. And another one that we've had is that's just come in is, should those with allergies be taking vitamin D during this period due to reduced sun exposure?
It's lovely.
Well, a bit ironic.
Yeah.
The weather today.
So vitamin D has been a very popular topic in research. Does low rates of vitamin D lead to allergies? And I see this in the COVID literature. Does a low rate of vitamin D lead to allergies? So we know people with darker pigmented skins, ethnic minorities are at greater risk of low vitamin D and of COVID complications. Is it that simple to say the one is causing the other? Probably not. There are many other receptors and other reasons for that. But certainly you don't want to take a chance. And it's a very easy thing to top up, to supplement with vitamin D. The national guidelines are for vitamin D supplementation till age 5 anyway, regardless of COVID, regardless of allergy. So it's an easy question. Yes, if you're less than 5 years of age and you want to follow the NHS guidelines, you'll be taking vitamin D. If you have a darker pigmented skin, most of your vitamin D is converted in the skin after ultraviolet exposure. So you then want to practice safe sun exposure. So early morning and early evening, you would go out now and get your vitamin D conversion. And that's a healthy thing to do for many reasons. Whether low vitamin D leads to allergy rates is being trialed in a proper randomized trial in some cross-sectional studies where you just take a photograph of a cohort in time. There are some hints that this is the case. When you look at latitude in America, those that are more cloudy, where there's less ultraviolet, less vitamin D, we know that more infant formulas were used and more allergy diagnoses were made and more adrenaline devices were scripted. Are those factors convinced? We're not sure. We've seen the same thing in Australia, which bizarrely with all the sunshine, vitamin D deficiency is not entirely rare because everyone is so scared and cautious to avoid the sun that folk with lower vitamin D seem to be associated with allergy. But those study designs aren't entirely rigorous, and they're very good studies to look at it. So to cut a long story short, supplement with vitamin D, enjoy safe sun exposure, and eat foods that contain vitamin D, are healthy for many reasons.
And let's hope in the next few days we get plenty of that sun. Another one here, because we have a number of calls to our helpline which relate to asthma and eczema because there's often comorbidities. One that we've received is, are you more at risk to this virus if you have severe eczema on your face and neck?
So that's a really good question. So COVID, its route of entry is often through mucous membrane. So around your mouth, your ear, nose and throat, your eyes, your conjunctiva, and then obviously inhaling it. Your skin is your largest organ surface area wise. If it is broken down and abraded, we know that it's a portal of entry for food. That's how most children develop their food allergies. They become sensitized through their skin whilst they're not eating it. And we know that in animal models and in humans. Does this occur with viruses? Well, we know that the skin is slightly immunosuppressed with eczema, and you're prone to many viruses, the herpes viruses and many more. And we know of these strange interactions between molluscum contagiosum, many of your kids would have had that, and eczema, where they flare up or the one suppresses the other. So viruses can influence the skin, they can infect the skin, they can influence the skin. With regards to COVID entering through eczema, I haven't seen convincing data. And when they look at risk factors such as ethnicity, obesity, smoking, underlying chronic illness, I haven't seen eczema come up in that data. So it's biologically possible. And of course, you'd want to keep your skin as well controlled as possible for many, many reasons. But I haven't seen data suggesting that puts you at risk of COVID.
Thank you, George. And another one's that's sort of related, it's regarding nurseries. So, and we haven't touched specifically on that topic so much this evening. My 18-month-old has severe allergies and very bad eczema, and we're concerned that his wheezing is undiagnosed asthma. Should we consider him more vulnerable during this crisis and therefore reconsider his return to nursery?
So in an 18-month-old with wheezing, it's very hard to know if that's going to turn out to be persistent asthma because they haven't lived long. 1 in 2 children will wheeze. Very few of those will go on to have asthma. So it's hard to know who is at risk. So children with egg allergy increases risk slightly. Children with eczema increases risk of asthma slightly. Children with a very strong family history will increase risk. So you can look at all those risk factors. But even then, there's absolutely no guarantee that the wheezing that your child has had is not just to some kind of infection. And it's very hard to know. Certainly, they wouldn't meet criteria for shielding. So there's no reason for your household to absolutely stringently lock down. I wouldn't take any extra steps other than common health interventions. Try an inhaler if you think that provides some relief. If that is frequently used on 2 or 3 occasions, in other words, the blue salbutamol inhaler, you would then introduce a brown puffer and see if that responds. If there's no response, it's probably not asthma and a different condition. Of course, there are many different reasons why 18-month-olds can start wheezing, and a pediatric opinion is always wise in that setting.
And another one for you. They're coming in thick and fast here.
Nice to speak to.
We often get asked about vaccines and immunizations generally, but there's particular concern at the moment while everyone is so concerned about the development of a vaccine for COVID-19. And we've had this question in a couple of times. Are you aware of a vaccine being developed that is suitable for egg allergic patients?
We're talking about a COVID-specific vaccine,
yes.
And we all know that there's none on the market as yet, and there are many, I believe over 100 different trials underway. I'm sure egg allergy is low on the developers' risks of priorities, but many live vaccines are cultured on egg. The reason is if you take the virus, it won't propagate itself. You need to infect cells, which are either egg, so you use the egg cells, the chicken cells, or the fibroblast, or mammalian cells. So you'd make a cellular vaccine. And then you would get rid of the cell and take the virus and either deactivate it or have it as a live vaccine. So some of these vaccines will probably be deactivated, altered, some will be live. The live will likely contain egg. But we know that egg-containing vaccines are generally safe for nearly all egg allergic children. So the MMR has an extremely good safety record with respect to egg allergy, as do the flu vaccines. The nasal and the subcut flu vaccines have excellent safety records. So hopefully, were there a successful vaccine that we could access, it would be safe for egg allergic children. Remember, egg allergy is generally outgrown in childhood, and a vaccine it'll probably be rationed in the beginning and probably not offered to young children. I'm not an immunologist, infectious disease specialist, but you would probably first use up your vaccine stock for those at risk who meet those risk factor criteria, ethnic minorities, older folk, chronic illness, and then you would move on to children. Because children generally, as I said earlier, they acquire this condition very infrequently. They seem to bear the illness very well with very mild symptoms. And when they do complicate with Kawasaki's or pneumonia, it's exceptionally rare.
Thank you, George. As I know you're aware, we very often get questions around vaccines of all types, and that's very helpful answer. I'm conscious of the time now, and I wondered if there was any general messaging that you would like to give to the listeners out there around behaviour, if you like, during this period.
Just a message of empathy. This has been an extremely stressful time, and in truth, it's probably only just getting going. It's only been with us for a few weeks. We've all had to lock down. You're looking after children with various needs of variable severity. And I would just say that folk have done very well managing this together. We're going to have to find our way out of this, how we only exist as allergists through serving allergic patients. So you're going to have to guide us, and we'll try our best to guide you, and we'll try and make sense the other side. Encourage folk to look after their mental health, their mental well-being. This has been very stressful for many reasons, and particularly, as I said, when looking after additional health concerns.
Thank you, George, and thank you so much for coming along this evening and answering all these questions for us. Certainly, I'm thinking around the questions that have been coming through to the helpline and through to this evening, and the sort of your very clear exposition of the facts and the situation. It has been great. So thank you very, very much for that. I would like to encourage everybody, thank you all for listening first of all, but also to encourage you, if you do have any issues that you feel you need advice on, do contact our helpline at the Anaphylaxis Campaign. The number's 01252 542 029. That's 01252 542 029, and we're open 9 to 5, 5 days a week. We are all working from home at the Anaphylaxis Campaign, but our helpline is still very much up and running, and our services are still being provided. And if you would prefer, you can also look on our website to see if you can, if the information you require is there, and that's www.anaphylaxis.org.uk, www.anaphylaxis.org.uk. Or you can email us if you have a query and perhaps you don't want to talk about it, or the thought strikes you outside our normal working hours. If you email us at info@anaphylaxis.org.uk, that's info@anaphylaxis.org.uk, we promise that we will get back to you. As I always say to people, I've got a great team of staff working with me. We don't know the answers to everything, but we certainly know a man or woman who does. And we have great supporters like George, who will always help us to give you the best advice. So I'd now like to round up this evening, and thank you again, George, for your help and support.
Thanks everyone for listening.